Hello. Today our group will be covering the disparities that people have in the Indian caste system and comparing it to the challenges immigrants in America face when accessing healthcare. The Indian caste system is a traditional system of social stratification that has existed for more than 3,000 years. Caste in India is assigned by birth and remains constant throughout life. Immigrants, when coming to America, face many challenges when assimilating into the country. Some lack the resources to access quality health insurance, and might fail to get the adequate care they need. Immigrants have consistently low rates of health insurance coverage compared to the US born population. An example of how the caste system has been created was due to Hinduism. The ancient Varna system divided Hindu society into initially four and later five distinct castes that are mutually exclusive and occupation specific. These five castes are the Brahmins, priests, Kshatriyas, warriors, Vaisyas, traders and merchants, and Sudras, those engaged in so-called menial jobs like agricultural and trading. And the Ati Sudras, or untouchables, are those doing the most despicable menial jobs like manual scavenging and sewer cleaning. The untouchables have the lowest social standing in society. Another way of categorizing the castes, which is now used in India to direct specific policies, is scheduled castes, scheduled tribe, and other backward classes, and general castes. People who belong to the scheduled castes are previously referred to as untouchables, while the scheduled caste are communities of people living in tribal areas, mainly within the forest. For Paulina's findings, in the United States, immigrant populations are often discouraged to pursue healthcare. The idea of biological sub-citizenship, which is defined as one's neglected rights to healthcare, and health, which is present in both populations. Having citizenship is one of the socio-political boundaries that separates immigrants from receiving healthcare. They are also not granted the same rights as citizens. The neoliberal policies of pro-market and public service cutbacks are, among other factors, as to why these populations are forgotten and do not receive adequate care. The caste system of India, as well, deprives the rights of these poor members of the community. So Fazal went to a community health center near his place to get the insights from a person belonging to the so-called lower caste, and asked him how caste plays a role in accessing healthcare services from their own perspective. He found a man around 40 years old who was there for a medical checkup. He belongs to the scheduled caste category. Initially, the man was not revealing his caste, but when talked to him for a few minutes, he felt more comfortable and opened up. One of the key quotes that he got from the 40-year-old man was, "No one is helping us because we are poor and belong to the caste." He questioned, why is it our fault that we were born into a scheduled caste? And then he talked about how, personally, some doctors discriminated against us. As you can see in the concept map, the people who belong to the scheduled caste depend on government healthcare services. They face many challenges and roadblocks. They might have financial instability, discrimination based on caste, while a lot of them are uneducated and illiterate and don't know about their basic rights. They might be taken advantage of within the hospital system. Some facts are that more than 50% of the scheduled caste and scheduled tribes population belongs to the poorest or poor category. We also find that infant mortality rate is also much higher than the rest of India. They could not reach medical facilities within their areas. Now coming back to America, We specifically looked at counties in California across our country. So California has 500,000 residents that are undocumented immigrants. Many undocumented immigrants make up the population of Southern California and the Bay Area. Undocumented immigrants are more likely to be uninsured and experience lower levels of health quality. The graph of California to the right shows the 2018 California Health Rating Report. Southern California and parts of the Bay Area ranked lowest in terms of health quality. The findings suggest that to improve health quality across California, it needs to be affordable and accessible healthcare to these vulnerable communities. We can see that this disparity doesn't just happen in California, but across the whole United States. And then we have some clips from personal accounts.
Of these institutions to provide them with care. In our training as American physicians, we have somehow come to accept the fact that the poor are less deserving of care than others. And when we attempt to make positive changes for these communities, we are up against large bureaucratic systems that seem difficult to navigate. I know this firsthand. At Pre-Health Dreamers, we were up against policies that seemed impossible to change, legal issues too large to tackle, and few who could help guide our advocacy efforts. Vulnerable communities should not be forced to go through these challenges. And like all vulnerable patients, medical professionals are needed on their side. I think about the moments when lawyers told me that I should leave this country because I would never amount to much as an undocumented child in the United States. I learned to keep my head low, not to ask for much, and to be grateful for the opportunities that I did have. But the
in preventive and promotive healthcare. But it's costly also in terms of what it does to the society in the long run, because what poor health or high morbidity rate does, it impacts cognitive ability. It leads to higher health costs in the long run for a society, which become unsustainable beyond a point, because remember, India also has a very large young population, which is going to age. So our median age is going to be increasing over time. And then we are going to be stuck with all these ailments, which are, lifestyle diseases. Diseases not just driven by underweight, but also overweight. We have all these new kinds of problems which are going to only get worse with time. There are huge disparities in the country. And the disparities are not just regional, because we have a state like Kerala, which compares to Japan, and which is way ahead of China in terms of not just spending, but also in terms of health outcomes. While if you have a state like Madhya Pradesh or Uttar Pradesh, then they really compare very badly, even to the Indian average.
Immigrant populations are particularly at risk in the present day. The number of children of immigrants is increasing, and these children face barriers to their health care that they need. Some of them are uninsured and have unmet health needs. And on the figure on the right, we can see that 35% of undocumented immigrant children do not have health insurance. This is an alarming number and provides an insight that undocumented children are underrepresented. In the second graph, we see Indian infant mortality rates between varying Indian states. The rural infant mortality rate is higher than amongst urban populations. The rural areas have less access to health facilities and care. For Miranda's findings in the graph, we see that undocumented immigrants in California are unlikely to have the usual source of healthcare. The usual source of healthcare can be beneficial because individuals can have a trusted and consistent connection to the healthcare system. This can lead to a better outcome. However, the undocumented are more likely to access safety nets for health coverage. Safety net providers are mostly federally qualified centers and rural health clinics. Many of these clinics are located in communities where undocumented individuals might reside, and they will provide care no matter their status. These safety providers are critical to serve the undocumented because many are uninsured and don't have the care from their jobs. Permanent residents and naturalized residents experience better health coverage than no usual source of health care. These health coverages are a mix of safety net providers and other providers. The second graph shows that 58% of California adults from age 19 to 64 in 2018 had employer-based coverage. As we see, it should be implemented where employers are incentivized to provide their employees with adequate health care. The graph shows that private providers and a mixture of public and private were seen to be preferred by populations with diseases when accessing healthcare. Private providers, while they are more expensive, were strongly preferred for its better and safer services across patients with conditions. In India, continuing efforts by the modern government to address the effects are occurring. However, they continue to face multiple disadvantages. About 50% of all maternal deaths in the country come from these poor demographics, and their children are more undernourished compared to the rest of the population. The map of India portrays accessibility and spatial distribution of medical amenities. Here we can see how many medical centers there are throughout the country, marked by the red dot. These municipal dispensaries are rather scattered and not uniform. This indicates that there are populations that are not receiving adequate care. The populations of people may not have the access. We've outlined some of the issues that the health system is facing, and now we have some resolutions. We can provide affordable, cheaper healthcare to immigrants. This would lessen the stress on both individuals and the collective system. And we can also add more community healthcare clinics to assist in this. Our second resolution is bringing awareness to the lower castes about their rights and special statuses in the Constitution for them that are there. So just bringing awareness to the services that are there, and then also implementing more health clinics within the rural areas. And that's it for our presentation. Thank you so much, and I hope you have a wonderful rest of your day.